present to you today my senior capstone project, implementing oxygen saturation levels, SpO2, as the sixth vital sign. What does that involve? That just involves one small change when you're recording your vital signs, and that's getting a SAT reading or oxygen saturation reading on your patients and recording it with the vital signs. Why is this important? It's important because your saturation levels tells how much oxygen is in your bloodstream. That is the definition of hypoxia. It's a low oxygen content within the bloodstream. Hypoxia is a serious condition that can lead to death. Hypoxia can cause damage to internal organs, such as the brain and the liver, within minutes. As you can see on the picture, the lady is experiencing hypoxia. As a matter of fact, she's the latter stage. She's cyanotic. Her lips and her nose is blue. How can we monitor oxygen levels? Pulse oximeters have been found to be a safe, non-invasive measurement. They come in many sizes and variations. They have now the technology for wireless pulse oximetry. Pulse oximeters have been used safely for years by the anesthesia department for evaluation of patients' oxygen during surgery. Why is this a major concern? There are a large portion of our population that aren't diagnosed, but frequently experience respiratory distress or hypoxic episodes. As you can see, that patient has an oxygen saturation level of 66%. In order to provide better care for our patients, we have to do thorough emission assessments and incorporate best practices. In patients that are receiving IV narcotics, it's recommended that they have oxygen saturation levels monitored. Why are these changes important? They're important because when you come into the hospital, if you're already experiencing respiratory complications or hypoxic episodes and you receive general anesthesia, that only compounds the problem. And we want to improve the patient outcomes, prevent complications, and prevent these patients from having unplanned admissions. Oxygen saturation levels will also help us to quickly evaluate patients and detect deteriorations in their conditions. Also, signs of hypoxia can go from patients showing signs of hypoxia can go from air hunger, confusion, or restlessness. If not detected early, these patients' conditions can quickly deteriorate. What we're trying to discover here, as my PICO question states, is if we implement pulse oximetry, will we be able to better care for our patients? Will we detect low oxygen saturation levels quicker and be able to intervene to prevent the conditions from deteriorating? Evidence for change. The Agency for Healthcare and Research and Quality recommends that as part of the preoperative assessment that these patients have O2 sat levels recorded. They also feel that this is a part of having a thorough respiratory assessment. The first case study that I reviewed was preoperative selection of adult patients with obstructive sleep apnea scheduled for ambulatory surgery. This was a randomized cohort study on ambulatory patients. This study was performed by a group of anesthesiologists that worked in an ambulatory care setting, and they wanted to evaluate whether these patients were good candidates for outpatient surgery or not. And they evaluated over 6,000 patients. At the conclusion of this study, they learned that these patients with the proper preoperative evaluation and assessments could be safely performed and have general anesthesia and go home the same day. But the preoperative assessment and preparation were key to these patients having an uneventful anesthetic. The second case study was the impact of pulse oximetry surveillance on rescue events and intensive care unit transfers. This was a controlled case study. This study was performed on a 36-bed orthopedic floor. All of the patients were monitored postoperatively with pulse oximeters. After implementing this study, they learned that these patients, there was a decrease in the patient rapid responses call and transfers to ICU due to respiratory complications. The nurses were quickly able to see that the patients were deteriorating and intervene, thereby preventing these patients from having to have further care. The third case study was design and implementation of wireless patient monitoring system for postoperative patients on general care floor. This was a cohort controlled study. This study was performed in Seoul, Korea. They implemented wireless pulse oximetry monitoring on a couple of the floors there. And they initiated 73 at the beginning of this study. And they found that they had such a great response. The nurses' time between getting the alert on their phone or their PDA was less than a minute before they were able to come in and implement something to prevent the patients from deteriorating further. So at the end of this study, they implemented pulse oximetry on all of their general surgery floors because it was evident that these patients' conditions were monitored closer and that they had better outcomes. The fourth case study was could preoperative diagnosis and treatment prevent complications. This was a cohort controlled study. This study evaluated patient outcomes between those with sleep apnea and those that were not diagnosed sleep apnea patients. Patients with chronic obstructive pulmonary disease and obstructive sleep apnea had worse outcomes. During this study, when they started doing preoperative planning for these patients and assessments including high-flow nebulizer treatments using their BiPAP and CPAP, these patients' outcomes were equivalent to the patients that did not have respiratory disease. Recommendations. We need support for this project from the hospital administration, our primary care physicians, our anesthesiologists, our nurses, all working together to improve the patient's outcome. Being patient-centered care and focusing on improving patient outcomes involves all disciplines of the healthcare system. And we all work to improve these patients' outcomes. Part of the recommendations also will be establishing protocols and policies that are implemented throughout the hospital to cover not only your general recovery room immediate post-op phase, but also to cover the patients on your general surgery floors. Why should we implement this change? We should implement this change because we'll be able to better identify those patients that are at risk for low oxygen saturations. And it also will assist anesthesia in their plan of care for these patients. And it also will assist us in doing a more thorough health assessment, physical assessment on these patients before surgical procedures are performed. How will we evaluate this? We'll evaluate this by monthly quality indicators, where we look at how many patients are received in your post-op recovery room with LMAs still in places or airways, how many patients are admitted to the hospital that were scheduled for outpatient procedures, how many will be transferred to your ICU because of respiratory complications. And a decrease in any of those things will show us that we have improved our care. In conclusion, research has proven that the use of pulse oximeters has improved patient outcomes. As patients present to the hospital with multiple disease processes, we have to seek ways to improve their care. Evidence-based protocols are known to improve patient outcomes, and this is one of their recommendations. We have the technology, the evidence supporting this change. Now we just need to implement it. Are there any questions? I appreciate your time and attention to this presentation, and hopefully we will see these changes taking place within our facility soon.